talking about are going to hopefully be illustrated in the case examples. And I'm delighted to introduce Chris Kyriakou, who is a postdoc who's did his PhD actually in PUL and ectopic pregnancy, and Margot Pikowski, who's currently working on her PhD in the same area, broadly speaking, and biomarkers. And they're going to show us some case examples on the topics we've been discussing this afternoon. So I'm going to hand over to Chris and Margot for their talk, and they'll be around to handle questions. Thank you.
My name is Dr. Chris Kyriakou, and I'm a postdoctoral fellow at Imperial College London. Together with Dr. Margot Pikowski, another fellow and colleague, we will be discussing case examples in early pregnancy care. The introduction for case 1 is as follows. Our patient is 35 years old, gravida 1, para 0, presenting at 5 weeks gestation based on last menstrual period, following a positive urine pregnancy test with right-sided lower abdominal pain without bleeding. We perform a transvaginal ultrasound scan, and after screening the uterus, cervix, and endometrium in transverse and longitudinal views, we measure an endometrial thickness of 11 millimeters as shown in this longitudinal view. A coronal 3D image following volume acquisition confirms the lack of intracavity structures noted on 2-dimensional screening, with systematic review of both adnexa only confirming the presence of a right ovarian corpus luteum. So after confirming these findings, our patient received a PUL, or pregnancy of unknown location classification. Now, we know that at least in the UK, the baseline rate of ectopic pregnancies is approximately 11 per 1,000, or 1.1%. However, ectopic pregnancies make up anywhere between 8 to 37% of a PUL population. So how do we go about identifying them? In the absence of ultrasound diagnostics, PUL management requires triage to high versus low risk in order to allow resources to be directed to those that need them the most. These mainly being the women with an ectopic pregnancy diagnosis, i.e. any pregnancy partially or completely external to the endometrial cavity, as well as a much smaller subset of women with a PPUL, or a persisting PUL. And these are pregnancies of unknown location that have 3 or more serial HCG levels that usually vary by less than 15%. Now, possible triage protocols used around the world are now shown alongside their ability to discriminate high-risk outcomes, presented using areas under the curve, or AUC. While single-visit protocols may be advantageous for throughput, HCG cutoffs perform extremely poorly, and progesterone assays are not widely used, but can also be quite expensive as well. 2-visit HCG ratio protocols have equivalent performance to single progesterone, but again, the AUC remains suboptimal. These inadequate protocols limit effective PUL triage whilst being inefficient and costly. So there are 2 solutions to this. The first is to improve triage performance. Access via this QR code is an external validation of PUL triage models, where the M6 model was shown to have superior performance. It works well without progesterone, so when only 0-hour and 48-hour HCG levels are available, and it outperforms any other protocols, including the HCG ratio. And we actually para 0, presenting at 5 weeks gestation, we measure an endometrial thickness of 11 millimeters as shown in this longitudinal view. A coronal 3D image following volume acquisition confirms the lack of intracavity structures noted on 2-dimensional screening, with systematic review of both adnexa only confirming the presence of a right ovarian corpus luteum. So after confirming these findings, our patient received a PUL, or pregnancy of unknown location classification. Now, we know that at least in the UK, the baseline rate of ectopic pregnancies is approximately 11 per 1,000, or 1.1%. However, ectopic pregnancies make up anywhere between 8 to 37% of a PUL population. So how do we go about identifying them? In the absence of ultrasound diagnostics, PUL management requires triage to high versus low risk in order to allow resources to be directed to those that need them the most. These mainly being the women with an ectopic pregnancy diagnosis, i.e. any pregnancy partially or completely external to the endometrial cavity, as well as a much smaller subset of women with a PPUL or a persisting PUL. And these are pregnancies of unknown location that have 3 or more serial HCG levels that usually vary by less than 15%. Now, possible triage protocols used around the world are now shown alongside their ability to discriminate high-risk outcomes, presented using areas under the curve, or AUC. While single-visit protocols may be advantageous for throughput, HCG cutoffs perform extremely poorly, and progesterone assays are not widely used, but can also be quite expensive as well. 2-visit HCG ratio protocols have equivalent performance to single progesterone, but again, the AUC remains suboptimal. These inadequate protocols limit effective PUL triage whilst being inefficient and costly. So there are 2 solutions to this. The first is to improve triage performance. Access via this QR code is an external validation of PUL triage models, where the M6 model was shown to have superior performance. It works well without progesterone, so when only 0-hour and 48-hour HCG levels are available, and it outperforms any other protocols, including the HCG ratio, and we actually access this via the use of a mobile application. The second solution is to move toward point-of-care testing. Now, this QR code links to a formal clinical study evaluating an ambulatory care system in PUL triage, and we now know that the published device is safe to use in this context, significantly improving workflow and bypassing laboratory costs. Improving PUL management in these ways is possible in any setting, and using them together is safe. Now, we did this with our case, where the M6 model identified the risk of ectopic pregnancy as being low, and as the model predicted the outcome was low risk likely in uterine pregnancy, the objective advice was to rescan in 7 days. Remember, the model is not diagnostic. It is a triage tool pending transvaginal ultrasound scan diagnosis of early pregnancy outcomes.
So our patient is brought back 7 days later as per the protocol, and we can see that the scan has changed. We can now see an intrauterine pregnancy with a gestation sac and a yolk sac. That gestation sac is measured in 3 orthogonal planes to yield a mean sac diameter of 9.3 millimeters, and there is no fetal pole present. The ovaries are unremarkable, and we can see that there is a corpus luteum on the right side. I also want to draw your attention to a small subchorionic hematoma, which is below the level of the sac, and we'll discuss this in more detail in just a moment. So this patient receives a classification of a pregnancy of uncertain viability, and how should we manage her from here? Well, the first thing to say is that the goal of PUV management is to avoid incorrectly diagnosing a potentially viable intrauterine pregnancy as a miscarriage. So we use this table to guide our follow-up interval. So we can see that if there is a fetal pole present on the initial ultrasound, we repeat the ultrasound in 7 days, and at that point we would expect to see a fetal heartbeat. If the gestation sac is 12 millimeters or more in size and there is no fetal pole present, we also bring back in 7 days, and we would expect to see a fetal pole at that second ultrasound. And if the gestation sac is small, as in this case, in other words, less than 12 millimeters mean sac diameter, we bring back in 2 weeks. And at that stage, we would expect to see that the mean sac diameter has doubled, or there is a fetal pole. Otherwise, we can diagnose a miscarriage. Key message here is that if there's any uncertainty, classify it as a pregnancy of uncertain viability. And a handy rule of thumb is that if you can see a fetal pole that's less than 7 millimeters, bring the patient back for follow-up in 7 days. If there's no fetal pole, but a mean sac diameter that's less than 25 millimeters, you can bring the patient back at 2 weeks for a diagnostic scan. And just to emphasize that the patient ultrasound that we've just seen is not diagnostic for miscarriage, because it does not meet the miscarriage diagnosis criteria which are set out below. So far we've talked about pregnancy of uncertain viability and transvaginal scanning, but what about transabdominal scanning? Well, first thing to say is that we need to proceed with caution, because there's no validated miscarriage criteria for transabdominal ultrasound. Do not use the gestational age from the last menstrual period. And best practice is to always classify an initial intrauterine pregnancy as a pregnancy of unknown viability and bring the patient back for rescan 2 weeks later. So the patient is brought back 2 weeks later as per our protocol, and we can now see a fetal pole with a heartbeat. So the final pregnancy outcome in this case is a viable intrauterine pregnancy. Our second case is a 36-year-old patient. She's had a previous miscarriage and she's 8 weeks into a new pregnancy, and she has presented with some PV spotting, which is pain-free. Now we can see that she has got a viable intrauterine pregnancy, but adjacent to that gestation sac, there is a subchorionic hematoma, which is level with the sac. And that subchorionic hematoma is quite substantial in size. How should we manage her from here, and what should we be telling the patient? Well, the most comprehensive study into subchorionic hematomas by Alma in 2020, which is signposted in the QR link, showed that 28% of the early pregnancy cohort will have a subchorionic hematoma. So the first key message, and the other finding from this study, was that there was no association between first trimester subchorionic hematoma and first trimester miscarriage. This is a common finding, and we can manage these patients expectantly. There's also no relationship between the hematoma size, bleeding, pain, maternal age, and risk of miscarriage. So our patient was brought back at 13 weeks, and also at 16 weeks, we can see that the subchorionic hematoma is still present, but actually by 18 weeks, it had completely resolved, and she went on to deliver a viable intrauterine pregnancy at term. The Alma study showed that there was a slight increase in the incidence of preterm birth. And the other key message is that any recurrent bleeding in early pregnancy, or if an intrauterine hematoma is identified, should prompt consideration of serial growth ultrasound and a progesterone administration.
We now move on to case 3. This patient is 23 years old, and she presents with lower back pain and spotting 3 weeks following the expected management of a miscarriage. We can see disrupted endometrial contents in this longitudinal view of the uterus, and these are consistent with retained products of conception. With colour Doppler applied, flow close to the implantation site is enhanced, whilst flow remote from the implantation site is not. And this is an example of enhanced myometrial vascularity, or EMV. So what do we do? Whilst the term AVM was used historically to describe this finding, this is no longer the case. Arteriovenous malformations are rare, aberrant connections that occur anywhere and persist. AVM and EMV are not synonymous. EMV, or enhanced myometrial vascularity, is naturally associated with retained products of conception and seen in approximately 1 in 20 miscarriages. This QR code links to an excellent summary paper on the topic. But going back to our case, what are the management options? We can leave it. This is safe to do so in the absence of heavy bleeding, but the course can be protracted over a number of weeks. We can treat it. This is for heavy or persistent PV bleeding, or just due to patient choice. Maybe the patient doesn't want to have a protracted course of management. With brisk bleeding, ultrasound-guided suction, ovoid swabs, forceps, or blunt curette are usually advised. Without bleeding, operative hysteroscopy with cold loop resection or selective morcellation is advised. Blood loss and complications are both usually minimal. Finally, embolization should be rare and very selective given the underlying pathology we have just discussed.
And our final case is a 39-year-old patient who's had a previous cesarean section, attends not knowing her last menstrual period, but is asymptomatic, and has essentially come in for a reassurance scan as she's not sure of her dates. Now, on the initial ultrasound, it looks like the cavity is empty, and But when we turn into the transverse plane, what we see is that adjacent, lateral, but not separate to the uterus, there is a mass. The adnexa are unremarkable. So what do we think might be going on? Well, we take a closer look and we can see that there is some vascularity surrounding the mass. And we also can see that the mass connects to the cavity with what we call an interstitial line. We also note that there's a fetal pole inside what looks to be a gestation sac. And this mass is illustrated also on the 3D ultrasound, which confirms that the endometrial cavity is empty. The HCG is 13,000 with a progesterone of 43. And our diagnosis at this point was of a possible interstitial pregnancy. So what is interstitial pregnancy? Well, it's important that when we talk about interstitial pregnancy that we're all speaking the same language. An interstitial pregnancy is when the blastocyst has implanted within the interstitial part of the tube. This is the most proximal part of the fallopian tube that lies in the myometrium. An interstitial pregnancy is not the same as a corneal pregnancy, and it is not the same as an angular pregnancy, even though sometimes these terms are used interchangeably. A corneal pregnancy is one that is within the rudimentary horn, and an angular pregnancy is one that is lateral to the angle of the cavity, but medial to the uterotubal junction. In other words, this is an intrauterine pregnancy. An interstitial pregnancy makes up 2 to 7% of all ectopic pregnancies. And I just want to highlight that the mortality is higher than for tubal ectopic pregnancies because of the risk of intra-abdominal bleeding. These types of ectopic pregnancy can be challenging to diagnose. The guidelines from the RCOG recommend that we look for an empty uterine cavity with a gestation sac that's lateral to the interstitial part of the tube and is surrounded by less than 5 millimeters of myometrium, and to also look for the interstitial line sign, in other words, the echogenic line from the endometrial echo to the interstitial mass. Summarizing about interstitial pregnancy, systematic transvaginal ultrasound is a gold standard for diagnosis, and 3D can also be useful. But be careful that we are not misdiagnosing angular intrauterine pregnancies as interstitial. The interstitial line and the Doppler play an important role in 2D transvaginal ultrasound diagnosis, and the mortality from these types of pregnancies is higher than for tubal ectopic pregnancies due to the risk of intra-abdominal hemorrhage, and therefore the management is mainly surgical. Occasionally, we consider expectant or medical management for carefully selected cases. And here is a list of all our references. And thank you to everybody working in the early pregnancy unit at Imperial College.
Excellent. Thank you very much, Chris and Christian. Thank you. This is very valuable, insightful. Again, case history. This will actually emphasize how important to adopt a multidisciplinary approach. I think it's probably being embedded now in the UK, where all early pregnancy acute gynae units they follow the MDT to share the thoughts for management such cases. And like Maya also mentioned in the previous session, the ultrasound is an adjunct. You have the patient and you treat the patient rather than the scan. The scan will help to rely, and especially with these advanced diagnostic models that you can apply, in all to be emphasized towards patient safe management. So I'm glad that these cases are fulfilling these criteria. Do we have any time, Tom, for some questions, or do we?
I think the general view is we've got to, unfortunately, and I've apologized to Chris by texting him online, I think we probably have to close because of it. We're running so tight for time. And I just want to thank Chris and Margot as well for doing such a great job, because putting cases like that together takes a lot of work, and finding the cases and finding the images. And I thought both Chris and Margot, I thought that they were really excellent cases and illustrated a lot of what we've been talking about today. So thank you, both of you. I'll leave it back to you, Osama, to close the session.
Thank you very much, Tom. I have to say, I thoroughly enjoyed this session. I hope our audience did as well. I can see a plethora of questions. Unfortunately, is not going to have the time to allow to answer them. We are breaking now for 20 minutes and just 10 minutes to 4 UK time, and hopefully with the last session of the day before the evening break, of course. And I hope you have a nice stretch with a good strong coffee.
Thanks, Osama, and thanks for sharing. It's great to see you.